fabulous and you got to find something else. And that is a hard time to switch. Yeah.
Thank you, Jamie. That was such a wonderful session in lightning speed also that we learned everything.
Oh yeah, I've got 20 minutes.
No, that was really good. And a wealth of information. So if you don't mind, please give us a handout. We would all love to know how to navigate these things. Thanks a lot. With that, we will move on to our next session, which will be by Dr. Powell. Dr. Powell completed his fellowship and residency at Washington University and his medical degree at Ohio State University. He is the vice chairman of medicine and chief of nephrology at UPMC McKeesport and an assistant clinical professor of medicine at UPMC. He is also an advocate and board member for the Western Pennsylvania Kidney Support Group and very involved in their polycystic kidney disease chapter. It's an honor to have Dr. Powell with us today. He was generous enough to come and let us know about the latest developments in dialysis and when to get on a list and few other things that we would all be waiting to hear about and want to know from a nephrologist. Let's welcome Dr. Powell.
Hello. Thanks, Shobha. Hello, everybody. I assume I'm talking to a national audience, I think, right? This isn't just Pittsburgh.
Yes.
Good, good. Now, I made a lot of slides, and I'll have Shobha move to the slides, partially because I still am not used to this Zoom world, and it's very distracting looking at myself in the, in the picture there. So, okay, next slide, please. So Shobha asked me to cover 3 things, and hopefully we can do that in 20 minutes. She wanted me to talk about transplant referral. That's obviously a very central issue. It's always fun to talk about new developments, and there are some new developments in end-stage renal disease and dialysis. And then I think we'll try to spend most of the time on sort of what to expect when you start dialysis. And obviously that's really a transition like no other. So first of all, so who is a candidate for kidney transplantation? Most people are candidates, but obviously there are contraindications. The first thing you have to understand from a nephrologist standpoint and really from a patient standpoint is that we consider kidney transplant the treatment of choice. We know that patients have better quality of life and longer survival. You know, if you can get a successful kidney transplant, and certainly it's your best chance at a normal life. You know, of course, there's issues with medicines, and you're trading one set of problems for another. But we consider kidney transplant the treatment of choice. Of course, age is the first question everyone always asks, and it's not an absolute contraindication. I will say that it's pretty rare to get a transplant over the age of 80. But if you don't have vascular disease or other significant comorbidities and are healthy and vital, we have had patients transferred or transplanted at that age. So a lot of people ask that, and you want to try to get on that list by the time you're 73 or 74 or 75, because as you know, the list can be anywhere from 1 to 5 or even 6 years. What are the contraindications? Of course, active cancer would be a contraindication, but certainly cancer survivors, depending on the type of the cancer, are candidates. You know, as long as you're anywhere from 2 to 5 years out, depending on the cancer type and the issues that you had. Certainly, you can't get a transplant if you have an active infection, but you can still get on the list. But the active infection, of course, would have to be cleared. certainly severe vascular or pulmonary or liver diseases might preclude transplantation, and they're going to look real hard for that. Obesity is a relative contraindication. We're not really supposed to even refer until the BMI is less than 40. They're losing weight actively and they're getting close to that 40. You're not going to get the transplant unless you're less than 40, and sometimes they even like it closer to 35. But we can't even refer until you're at least close to 40. There are some disorders, glomerular diseases that can recur in the transplant, and sometimes those patients might be better off not getting the transplant because of the recurrence. Next slide, please. So when is the referral made? When your GFR is 20 or less, we can refer for transplantation. Some centers want to see that for 3 months, but certainly if you're someone who's been real close to that and then you hit 20, we're gonna hit that referral button, and your nephrologist will do this. They're not the ones that are going to determine if you're a candidate for transplant, but they're the ones that are going to make the referral, and this is routine for their office, so they know what to do. And it'll take about 6 weeks usually before the transplant center really gets involved. They have to go through committees, they have to gather records, and then they have committee meetings, which are usually just once a month. But yeah, the nephrologist just makes the referral to the center and is not involved in whether or not you're a candidate, just in referral. And we are very liberal. We want them to say no. And of course, you want to get on the list as soon as possible because the clock is ticking. And as we said, you want to get on that list because sometimes it can take up to 5 or 6 years. Next slide, please. The emphasis now is on living donor transplant. You can see this is a very old slide. Over when transplant started, the list was often 1 or 2 years, but then the pool of potential recipients, went up, and there's all this emphasis on safety, and there's, the pool of donors did not rise with it. And I don't have current data, but even since that time, the list has grown. I think they say there's 100,000 people in the country right now waiting for some sort of transplant, whether it's heart, liver, lung, kidney. And the big emphasis, of course, is on living transplant for a couple reasons, as we'll talk about. There's also something called extended donor kidneys. So older people who may previously not have been the best candidates, and they didn't want to take it from they didn't want to give a young kidney to an older person who might not have as long to live. Now they have this thing called extended donor where they use sort of older kidneys, and really the success has been pretty good. So that has sort of extended the pool. Next slide, please. Again, the advantage to a living donor, first of all, is that you can time it. You may not ever need dialysis. I mean, that would be the hope. And we always say we're doing our job if our patient gets a transplant without ever needing dialysis. So shorter time on the list or no time on dialysis. And then, of course, the real advantage is the survival of the living transplant is much higher, in some cases almost double a deceased donor kidney. And that varies individually. There's no doubt about it. I've had deceased donor kidneys over 30 years. What these numbers are, the half-life, what that means is that at that year, say 8.8 for deceased donor, half the patients will still have a functioning allograft. And so, it's not just 8.8 years. Those people might, go 20 or 30 years. And then, of course, for the living donors, usually most people quote about 16 years, where half of those kidneys are still functioning. Next slide, please. Who is a donor? Really anybody can be a candidate, a relative, a friend. Some people just hear a calling, and there's all these new mechanisms of trying to get a transplant and just do it for benevolence. They feel blessed with what they have in life, and want to do something for someone else. Sometimes someone just answers the call. Now, they do have to be in very good health. It's a very rigid screening process, but they don't have to be in perfect health. For instance, you can have high blood pressure and still donate, but it has to be well controlled on just a single drug. It is a rigid screening process. And the truth is, people that donate have a lower risk of kidney failure long term than the average person. And the reason for that is that they're so good to begin with. You have to be very healthy. Now, to give someone a transplant, you have to be ABO compatible. What that means is, for me to give you a transplant, I would have to be able to give you a blood transfusion. And obviously, that isn't always the case when you find a donor. And in those cases, then they have a donor exchange program where your donor would give a kidney to another person, and their donor would give you the kidney. So they have swap programs. So just because someone can't give you a blood transfusion doesn't mean they can't be the person that's really getting you the transplant. Okay, next slide, please. So new developments, and obviously there's been some exciting things going on, with the xenotransplantation. There have been both cardiac and pig kidney transplants, and certainly that was sort of the hope, that now you're going to have this increase in kidney availability, donor availability. But that's going to be years away at this point. If we have time to talk later, maybe we can talk more about it. There's only been one kidney transplant to a non-brain dead person, and the person died in about 2 months. That was in March of this year, and there were definitely some findings in their immune system that were a little different than a human-to-human transplant. So a lot of things have to be worked out, and that's probably not something that's going to be routinely available for a long time. But the other thing is this wavelength AV fistula, and I'm talking from Pittsburgh. And in Pittsburgh, believe it or not, is the home of the wavelength fistula. We've done more of them in Pittsburgh than any place in the world. In Butler, PA, which you guys has been made famous over the last 2 weeks, where the ex-president was nearly assassinated, is a small town north of Pittsburgh. It really is kind of a small town, about 30 minutes north of Pittsburgh. But the person who's done more of these than anyone in the world is a gentleman at Butler Hospital. And now everyone in the city is starting to do it. Right now, the wavelength fistulas are less than 1% of all fistulas performed. In Pittsburgh, I think it's around 5%. But that probably will change in the future. And although that being said, the verdict is still probably out. So what is a wavelength fistula? Next slide, please. So, of course, a regular fistula, I think a lot of you guys are probably familiar with this, but if you're not, I'll explain how that is done. So there's two suitable veins, the cephalic vein and the basilic vein. The basilic vein is the real deep vein in the arm, where we can create a fistula or a graft. And what they do is they cut the vein and they tie it into the side of the artery, either at the wrist, on the thumb side, in the snuff box there, or near the elbow. But what you're doing is you're literally cutting the vein and doing an end to side anastomosis, and the vein then is getting tremendous blood flow. If people don't have a suitable veins and arteries, then we often use a graft. We put in a graft, which is basically a plastic type material that connects the artery and the vein, and then we put the needles in the graft. But we always prefer a fistula because they last longer. Next slide, please. So, and then what happens with the fistula, it has to mature. So it has to get big and dilated and muscular. So you can see the muscular lumen in that vein has to become arterialized. So you can put the needles in so it'll seal the needle and blood won't leak around the needle. And of course, it has to get big enough for the needle. Next slide, please. So what is a wavelength fistula? So a wavelength fistula is one that is non-surgical. It's done in interventional radiology. And first of all, you have to have the right anatomy, and about 85% of people do. And the interventional radiologist will find this thing called the perforating vein and do it from the ulnar artery, which isn't the main artery. So it doesn't get as much flow. Next slide. And then he will basically put catheters in both of them, and the catheters have magnets that connect the artery and the vein, and then with radio frequency energy, the artery and the vein are sort of sealed together, and then you cut a little hole with a little slicer that's built into it. And on the fourth picture there, you see arterial blood going into the vein. Now the nice thing is it's just slower. It doesn't, you're not sticking the vein into the side of the artery, where you suddenly have just arterial pressure in the vein. A vein normally has a pressure of 2 or 3 versus an artery of 130 or 40. So the vein doesn't get as big or aneurysmal. Next slide, please. So the theoretical advantages of this type of fistula is that it's not as large or aneurysmal. Hopefully it's going to last longer for that reason. It's not surgical. It's done in interventional suite. There's lower flow. We think less heart failure. People get what's called high output heart failure when you have these big fistulas with really rapid flow. And then you're going to steal less blood from the hand. So some people you have to tie off a fistula because it's just taking too much blood from the rest of the arm. So those are the theoretical advantages. And next slide, please. The potential disadvantages, you sometimes does require multiple procedures to dilate the vein up a couple times or tie off competing veins. It is lower flow, so there's concern about maturation, but the initial data of about 250 patients has been comparable to fistulas, and in some cases better. And then the dialysis units are less familiar. So it is sort of a little bit of a crisis when the unit gets their first patient. And the company that does this actually sends people in to sort of show them how to access the fistula. And again, this is a new thing, the way things work. Ask me in 10 years, is this the best idea? But it is new, and so far their data is very good, and there certainly are theoretical advantages. Okay, so what about dialysis? So I guess we should separate this into peritoneal dialysis and hemodialysis. So the first question with peritoneal dialysis is when should you have the PD catheter placed? And you can wait till within a month because it takes about 3 weeks when you can really start using it well. So in some cases you can say you can wait till the end, but you don't want to wait till the end to where you're sick, and then they might feel you're not a good surgical risk at that point. So another option is to actually put in what's called a buried catheter, where they actually bury it under the skin and then marsupialize it when it's time to start. So they have it buried under the skin, and when it's time to start, they just make a little nick in the skin and pull it out. Next slide, please. And back to that, so we usually refer people when the GFR is less than 15. We have them see the surgeon, and if they're a candidate for a buried catheter, we recommend that, an embedded catheter. Certainly the other issues, if you have like a hernia, that would have to be fixed. Sometimes they can fix it in the OR. You should make sure that your surgeon has been trained in what's called advanced laparoscopic technique for PD catheter insertion, where they do all four of those things mentioned: tunneling, the omentopexy, adhesiolysis, and hernia repair. And I think most surgeons are, and most nephrologists sort of want just one or two guys doing these catheters, because we don't do that many of them, and you want someone who does them, a lot of them, and who is fully trained in that technique. Next slide, please. And then what about training? So, of course, when you start PD, there's a lot of travel back and forth to the unit, sort of intense training. Your head is spinning, and that's the other reason not to sort of wait till the end. You want to have a little bit of a clear head to try to absorb all the information. They'll make a home visit out to your house and make recommendations about how to set things up. But it can be a little overwhelming. Next slide, please. It is a new technology, and there's sort of a lot of dynamics that can come with it. So with PD, of course, it's a much slower process. You're just putting a catheter into the dead space of the abdominal cavity, and then you're putting fluid in there, and that fluid slowly equilibrates with the peritoneal membrane that is very vascular and pulls the toxins out. Next slide, please. And again, this is new technology. It seems really scary when you first start, and a lot of people say, I could never do this. And that's why we always show patients videos of patients who do them at home. And they realize, some of these patients that show you what they're doing, they're older and they're not tech savvy. It's really not that hard. It looks harder. For instance, what you're looking at in the blue part there, that's just a cartridge. You just plug the cartridge in. You don't have to make all these crazy connections. You then make connections, but it's just a cartridge. It just plugs in, and even the whole computer area is pre-programmed. You just need to know a few things: turning it off, turning it on. So it really is pretty simple. Next slide, please. And then, of course, you have to have things set up in the bedroom to facilitate things, and it is an interruption into the bedroom, and that's another stress. Now, most people have a caregiver, and that should be a good thing. You should have this loving dynamic with a caregiver, but as we know, that's often not always the case. There can be issues sort of with control, and then maybe one of them blames the other one, or they're not pleased, with how much they're paying attention. So sometimes the caregiver issues can be stressful, but you need a good caregiver. We always like to have a caregiver, a second caregiver with PD, but a lot of people don't, and they're independent. They do it themselves. So next slide, please. And then, hopefully quickly you'll start feeling better. One thing is you have to be able to move your bowels well. You don't want to be constipated when you have all that fluid in there. So that's something that they emphasize on. And then you sort of negotiate your time on dialysis. You would like, we try to not do dialysis 7 days a week, especially at the beginning when you have some kidney function. As Kathy, the dietitian, was talking, there's differences between different forms of dialysis. So people on PD, because they're doing it more frequently, can drink more fluid. They can eat more potassium usually. So there are some really advantages to diet, and diet's not always the same for every dialysis patient. So hopefully you're feeling better, and it's a good lifestyle, and you have your days free. You can even do 2 out of 3 televisits with your provider. Next slide, please. So hemodialysis, I know I'm running late on time, so I'll talk fast. We want to have a functioning access when we start dialysis. So we usually recommend referral to the surgeon when the GFR is less than 20 or 18. It can take up to 6 months for a fistula to be mature, so you want to have that mature access before you start dialysis. So we want early referral. Okay, next slide, please. Now, starting dialysis, hemo is a little different. I mean, the dialysis unit can be a very scary place, and already you're going through this loss of kidney function. You might not be feeling well, and now you're going to this space with sometimes 15 other people getting dialysis at the same time, bells and whistles going off, noises, all these new caregivers. When you first, the next slide, please. When you first start dialysis, you're in this chair and you're hooked up for 3 or 4 hours, and I never really understood it until I got stuck on a runway once for about 4 hours in a middle seat, and then I really understood what patients are going through. Dialysis is much faster, but the problem is you sort of wring you out a little bit, and sometimes you don't feel well because of the rapid shifts of electrolytes and fluids, and it really is a procedure. There's dynamics with the caregivers. You might have one person who gets your needles in right away, another person who doesn't, and that can sometimes develop mistrust. So it is a dynamic, and really you need to be prepared for that when you start the treatments. And then, of course, adjusting to diet, when to take your blood pressure medicines. Those are all things you really need to make sure they're explaining to you when you start. Next slide, please. And of course, for any patient, whether it's transplant or PD or hemo, it's a loss, right? Just like losing a loved one, losing your kidney function, and people go through all the stages of grief, denial, anger, bargaining, depression, and then finally acceptance and resolution. And we don't know what stage you're going to be at when you hit that dialysis unit or the PD training. So we have to be aware of that as well. And our job is to make you feel like the glass is half full and not half empty. And of course, I think a lot of people, when they start, the glass is half empty. It's not half full. And that's something we have to overcome. So that is my last slide. I'm sorry I went over a little. I'll leave it up to questions.
Thank you, Dr. Powell. We already have a few questions. Let me just start with one of them. Isn't a slower BFR better on the cardiovascular system? We are very much on dialysis hard on the heart.
With the different fistulas, you're right. So it's not so much the blood flow of the dialysis; it's the amount, the fistula, the amount of arterial flow that's going into the vein. So if you have this large shunt, it can create something called high output heart failure. So yeah, the lower flow system, like a wavelength, might be better long term. That's certainly the theoretical advantages. But you're right. As far as dialysis, if you're someone that is having stressful treatments, lowering the blood flow can be helpful. There might be less disequilibrium, less drops in blood pressure because there's less shifts of